Hello. Hello. Okay, good evening. We'll start off today's session with a discussion on urolithiasis. This question was asked as an essay in previous years, that is around 4 or 5 years ago. Now, this question doesn't come up as an essay, but few short notes are frequently asked from this topic. So, we'll discuss this topic entirely. Urolithiasis as such is a disorder where there is a stone development in the renal system. The prevalence of it is around 1 to 20%. Majority are picked up by frequent use of ultrasound scans for in one way or the other. So the causes are multifactorial. So usually, if you have a stone disease, you have a high chance for recurrence within the first decade after the treatment. There are many risk factors associated with stone formation. Some are modifiable and some are non-modifiable. So what are the non-modifiable risk factors? First is the age. In males, the peak incidence of this disorder is around 4 to 6 decade. And in female, there is a bimodal pattern where it is a high incidence in the third decade and in the postmenopausal age group. Males are twice more affected than females, and white people are more affected than the rest of the things. You have hereditary forms of stone disorder where you have disorders like cystinuria, type 1 renal tubular acidosis, primary hyperoxaluria. And if you have a family history of urolithiasis, then you have 2 to 3 times more likely to have this disease. Modifiable risk factors becomes environmental factors, that is, people who are living in hot, humid regions, deserts, tropical regions, all those individuals are having a high incidence of, high chance for urolithiasis, whereas certain drugs like corticosteroids and chemotherapeutic agents, which actually predispose to stone formation through their metabolic effects. So you have something called as a the pathogenesis of urolithiasis, where there is something called as a culprit salts. So that is increased amount of calcium and oxalate that actually overwhelm the inhibitory factors of stone disease like citrate, potassium, magnesium, and the pH change. So that leads to the precipitation of these crystals. And when you have an acidic pH, more likely to have uric acid stones, and in alkaline pH, there is a high chance for calcium phosphate stones. So what happens is that when they precipitate into crystals, they usually get washed off in urine, or they anchor to a renal papilla, and that forms the Randall's plaque. And there is something called as a stasis stones, where stasis of the urine promotes the stone formation, and they are multiple, round, and having a smooth surface, and they are called milk of calcium stones, which can be asked as a one word answer, 1 mark question. So what are the types, different types of stones? The most common variety would be calcium oxalate. Okay, so it consists around 60 to 80% of the stones, and you can this can be associated with hypercalciuria or hypercalcemia, hyperoxaluria, hyperuricosuria, or hypocitraturia. So all these things predispose to the formation, and out of which the most common metabolic abnormality would be the hypercalciuria. Then you have other things like calcium dysregulation in the intestine or bone or kidneys, and hyperparathyroidism sometimes lead to hypercalcemia. All those things leads to stone formation. Hyperuricosuria, that is increase in uric acid crystal formation along with acidic urine, and once that crystal formation occurs, there is calcium oxalate crystals aggregate on that. Then you have calcium phosphate stones, which are relatively rare. Two types are there, apatite and bruchite stones. Sorry for the spelling mistake. That is associated with infection, and bruchite stones is usually seen in the distal renal tubular acidosis. Then you have other conditions like gout or myeloproliferative disorders, all those things leading to stone formation. Then you have infection stones. They are again struvite and apatite stones. Usually you have urease producing bacteria. So they are usually caused by Proteus, Klebsiella, Serratia, or Enterobacter. And what happens is there is alkalinization of the urine take place, and urea hydrolyzes, this urease hydrolyzes urea to carbon dioxide and ammonium. Another variety of stones which is asked as a short note is staghorn calculi. So what is peculiar about this is that it has grows in a branching pattern, and it takes the forms of the pelvic calyceal system, and actually causes a lot of morbidity, and sometimes it affects the renal function due to the obstruction as well as the chronic infection. So complete clearance of this stone is usually needed, but after treatment, even after treatment, some residual fragments or pieces remain, and that leads to a rapid recurrence of these things. So if you have a staghorn calculi, you need long-term chemoprophylaxis. Drugs has to be given for a few months, even after the removal of the calculus. Then comes cystine stones, relatively rare, 1% stones, and it is an autosomal recessive inherited disease. There is decreased resorption of cystine from the intestine and the proximal tubule of the kidney. So cystine is insoluble even at physiological pH, and these are very hard stones due to the disulfide bonding in between there, and this doesn't fragment with shockwave lithotripsy. So you need to look for other modes of treatment for them. So how does all these stone diseases present? Many, as I told earlier, are incidentally detected due to widespread use of ultrasound and other imaging. and symptomatic stones are thus picked up. But symptoms actually depends upon the size of the stone, location of the stone, type of the stone, whether it is infected or not, or whether any complication has set in. So usually you have microhematuria or gross hematuria, renal colic, calculuria, and ureteric colic. So what is this ureteric colic? This is usually asked as a short note, ureteric colic. So that is hyperperistalsis of the ureteric musculature against the obstructing stone. So presents as excruciating sudden flank pain, radiating to groin, scrotum or labia. So these are usually seen in the lower ureteric stones close to the uretrovesical junction and presents as increased frequency and urgency. When the stone is close to UVJ, increased frequency and urgency. Sometimes rarely presents as malaise, weight loss, if the stone disease is a long-standing one or the patient is having a renal failure. When you have a rigor and chills associated with this pain, you suspect urinary tract infection. So, what are the complications usually associated with this? You have significant morbidity, especially due to this pain, but the main trouble making complications are one is infectious complications and the other one is loss of renal function. So you can have multiple stones obstructing the bilaterally obstructing the ureter, especially if the patient is only having a single kidney and the patient can present with anuria, that is called as a calculus anuria. Then infectious complications like pyelonephritis, pyonephrosis, renal abscess, septicemia. If untreated, the renal abscess, pyonephrosis, all these lead to septicemia. And rarely you have more serious complications like xanthogranulomatous pyelonephritis or pyeloenteric or cutaneous fistula, where the diagnosis is missed or the treatment is neglected. So, coming to the diagnosis, you can have this presentation in an emergency setting or a non-emergency setting. So, if the patient presents with pain, the drug of choice is NSAID and paracetamol. So, you try to alleviate the pain. You look for the renal angle tenderness. First thing to do is, if female, you exclude pregnancy and ectopic pregnancy because this can be due to a clot colic or a papillary necrosis, and it may be the pain may be mimicking when the condition is an inflammation of appendix or in an ectopic gestation, ovarian torsion, or the patient may be sometimes malingering. So you go for urine and blood investigation, as I told earlier, rule out pregnancy by beta HCG estimation, X-ray KUB, ultrasound abdomen pelvis is usually the first line of outflow obstruction. You may have to go for an emergency decompression, especially in obstruction as well as in sepsis. Blood and urine culture may be done and broad spectrum antibiotics prescribed. Sometimes you may go for a ureteric stenting also. So stenting or percutaneous nephrostomy in acute obstruction, and you go for evaluation of the pH, urine examination for the presence or absence of crystals, blood, all those things, and blood level estimation of phosphorus and acid. These are done to rule out hypercalcemia, hypophosphatemia, and hyperuricemia. So how are they managed? You can have any modality of management. One is conservative wait and watch policy. This is usually when the stone is non-obstructive and the stones are less than 5 mm in size, especially located in the lower pole of the kidney, and the patient is having a preserved renal function. Otherwise, you can go for medical expulsive therapy, promote more expulsion of the stones by prescribing them alpha blockers like tamsulosin for the relaxation of the distal urethral muscle, or you can go for mechanical fragmentation of the stones like shock wave. This generates acoustic pulses, and they are focused on the stone and fragment due to direct energy or due to collapse of the bubble inside the stone. So there is a term called Steinstrasse, that is meaning of street of stones. So they are a row of closely gathered stone fragments, usually found in the distal end of the urethra. So this occurs when the stone disease is so high or when the stones are very hard. So usually asymptomatic and passes off spontaneously, but sometimes they can cause obstruction and surgical intervention may be needed. This may be asked as a one-word answer uh, question for 1 mark. So then there can be insignificant residual fragments. So that is clinically insignificant residual fragments, which are residual stone fragments less than 4 mm size. These are seen after treatment and usually pass off spontaneously, but around 20% they remain there, and they form as a needles for the regrowth of the stones. Then comes surgical management. The indications are failure of medical treatment, impaired renal function, chronic infection, especially in matrix calculi and staghorn calculi. You have high risk occupation, especially in long distance truck drivers, pilots, sailors, etc. And some patients come and ask for a surgical management, patient preference. So you have endourological procedure, which is the current preferred mode of treatment. Basically, that is minimally invasive. You have a lot of advancement in the field of endourology, especially in the use for stone fragmentation. Usually, the energy sources used for stone fragmentation would be pneumatic or ultrasound or laser. Okay, so you can have a procedure known as ureterorhinoscopy, URS, asked as a short note. So they are long, thin scopes used to remove the ureteric and renal stones. So they have working channels. They help in removing these stones, especially by using energy sources, graspers, and baskets. Okay, so yeah, they can have semi-rigid, or you can have pneumatic lithotripper or laser energy. So when you are using this, uh, it can cause ureteric perforation, avulsion, or retropulsion. Then you have something called as RIRS, that is retrograde intrarenal surgery. So these scopes are slimmer and more flexible than URS, and the tip can be deflected, and the laser is the technology used for actually it's used in less than 2 centimeter stones, which are situated in the lower pole, and the patients who are having musculoskeletal deformity and bleeding diastasis. Then comes the old technique which is called as a PCNL, that is percutaneous nephrolithotomy. Basically, you are creating a track between the skin and the pelvic calcium system. The patient is prone position, and under fluoroscopy or ultrasound, you are then there is another thing called as a mini perc, maybe asked as a short note, miniaturized percutaneous nephrolithotomy. So again, this is indication is still smaller size. Channels are created between the skin and the renal, the kidney. So standard PCNL track would be greater than 28 French. Mini perc would be less than 22 French. So in PCNL, the patient is prone. Here the patient can be lateral or supine, and you can treat the stones. Then non-endourological surgical management would be open surgery, that is pyelolithotomy or nephrolithotomy. So how do you prevent this stone disease? So these people who are having a high risk for stone disease are usually asked to follow certain general measures. They are asked to drink a fluid intake more than 2.5 liters per day. They are asked to take dietary calcium, supplementary calcium if necessary, if your meals are not containing more calcium, and this calcium should be taken at meal times, and reduce the intake of animal protein and salts. So these are the preventive measures to be taken. So I have mentioned what are the important subtopics in this urolithiasis, which may be asked as 1 mark question or a short note for 5 marks or for an essay. Okay, with that urolithiasis topic, we will move on to the next one. Okay, the end of this one. Okay. Hello, can you see the screen? Hello. Okay, so coming to the next topic for discussion, uh, which is usually asked as an essay. So this was asked in the one of the average examination. So the question was, discuss the pre-malignant conditions for carcinoma penis, elaborate on clinical features, investigations and management. A direct question. So we'll discuss the topic as a whole, and then we'll highlight the important ones. So the carcinoma penis etiology. So usually it is the human papilloma virus 16 and 18, and there can be lichen sclerosis or the effect of skin. It says that circumcision soon after birth gives immunity. Later circumcision doesn't have the same benefit. So contributory factors and precancerous states are there. Phimosis, which is inability to retract the preputial foreskin, and chronic melanopostitis, where the preputial sac and the glans penis both are infected. So that also leads to carcinoma penis, and you can have precancerous state like leukoplakia of the glands and penile intraepithelial neoplasia, that is PEIN. So how do you confirm all these things? You go for biopsy, MRI, and regional node assessment. So what is penile intraepithelial neoplasia? It can be called as, or it is also known as carcinoma in situ or Bowen's disease or erythroplasia in curine. So PEIN usually presents as red cutaneous patch over the penis. If this is present as on the glands, it is called as the erythroplasia of Curette, and if it is present as on the shaft of penis, it is called as the Bowen's disease. So, how do you treat these pre-malignant condition? You go for biopsy, then you go for carbon dioxide laser ablation, or 5-FU cream is applied topically, or you can surgically remove. These are the treatment for this precancerous condition. So what actually is the pathology in carcinoma penis? It is squamous cell carcinoma arising from the skin of the glands or the prepuce. So it can be a flat type, an infiltrating type, or a warty in appearance. So when the tumor is confined to the skin, you call it as a T1 tumor. If it invades corpus spongiosum or cavernosum, it is a T2 tumor. Urethral invasion indicates that it has become a T3, and invasion of adjacent structures, it becomes T4. So N1, N2 means your inguinal nodes are involved, and N3 means iliac nodes are involved. Distant metastasis can occur, but it occurs very rare. So how does these people present when they have this malignancy? They present usually very late because they are basically reluctant to show this because of embarrassment, or they might have thought that that is something else, misdiagnosis, all those things. So whenever they come very late, usually there will be a fungating or a large ulcerative or ulceroproliferative growth, which is obviously infected and foul smelling, and can lead to foul smelling discharge or blood stained discharge. Pain may be there or may not be there, and majority of people, around 50%, will have inguinal lymph node enlargement. It is thought to be due to infection of these ulcerated areas. So the prepuce sometimes may be non-retractile, and the patient may present with a narrow stream of urine or a foul smelling discharge or a thickness there. So you may not be able to retract the prepusal skin. So you need to split the prepusal skin to view the lesion, and then a biopsy is needed. So if such situations are not treated, what happens? The whole of the glans penis is replaced by a growth. These inguinal nodes, which are enlarged, will erode the skin in the groin area. Also, they erode the femoral or iliac vessels. Depending upon the nodal status, profuse bleeding and death can occur. So, treatment of carcinoma penis is basically treatment of the primary and treatment of the inguinal nodes. So, if the disease is confined to the penis, the prognosis is said to be best. Around 80 to 85% of 5-year survival will be there. But the moment the nodal involvement is there, the survival drops to 40%, becomes half. Another important prognostic factor will be the grade and stage of the disease. As you all know, low stage or a lower stage and a lower stage and a grade disease will be having a good prognosis. So you can go for organ preserving surgery or a limited excision, or you can go for Mohs micrographic surgery, or you can ablate the tumor. So basically, the old scheme of thought was a surgical excision for the tumor with a 2 centimeter wide margin. But as the technology advancement and the newer improvement in the drugs and the treatment modalities, recent advances, etc., you are now contemplating with a conservative surgery with a lower margin of tissue. So, if this tumor is affecting the glands, you go for a glandsectomy. More advanced tumor, when the muscle is involved, you can go, depending upon the site and size of the tumor, go for a partial penectomy. And very advanced cases, total penectomy. And once the total penis is lost, you can reconstruct the urethra with a perineal ureterostomy. Okay, so metastatic disease, same. you go for a wide excision for local control, and you first go antibiotic administration. You give some antibiotics for this enlarged lymph node, see whether it is coming down or not in size. So then you plan your treatment. So if you have a palpable node, you go for a USG guided FNAC. If that FNAC come as positive, you go for an inguinal block dissection. So situations are there when the nodes are not palpable. Again, there is a concept of sentinel node biopsy here. You go for a dye injection, take out the node, that is a Cabanas node. If positive, you go for an inguinal lymph node dissection. And management of pelvic nodes, that is N3, is actually controversial. CT may show supposed to be a positive node. If that is there, surgery actually doesn't have a much role. So in N2 disease, you can have pelvic lymphadenectomy, radiotherapy, and sometimes observe if the nodes are less than N2. And chemotherapy actually is ineffective in such cases, and it is reserved only as a palliative mode of treatment for metastatic disease. So this is in short the treatment for carcinoma penis. So we have discussed the pre-malignant condition, that is the penile intraepithelial neoplasia, Bowen's disease, erythroplasia and Querette, the etiology like HPV 16, 18, risk factors like lichen sclerosis, smoking, phimosis, chronic balanoposthitis. So clinical features usually presenting late, so ulcers, foul smelling discharge, ulceroproliferative disorders. So they present as muscle carcinoma, can be flat, infiltrating or warty type of lesions with or without lymph nodal enlargement. So the management becomes after confirmation of the malignancy by biopsy. You can go for circumcision or a dorsal slit or a punch biopsy, and investigation would be chest X-ray, CT scan of the abdomen and pelvis, or ultrasound, and stage the disease and then management of that. So usual thing is treatment by wide margin, but if it is confined to the glands, more conservative glandsectomy, to the penis, partial penectomy or total penectomy with perineal ureterostomy, and then we have discussed the management of the nodes also. So with that, we come to the end of this treatment for carcinoma of penis. Okay, thank you.